Welcome back to the Deep Dive. Today we are jumping into an area of human experience that is notoriously sensitive, incredibly personal, historically just frustratingly oversimplified.
We really are. We're talking about the understanding and treatment of female sexual function.
And we have compiled a fascinating stack of sources for you. I mean, everything from cutting-edge neurochemistry and pharmacological trials to
detailed psychological experiments and even daily diary studies on couples. It's a really multidisciplinary look.
And our mission for this deep dive is, well, it's pretty straightforward. We want to give you a genuinely thorough, multifaceted understanding of what's called female sexual dysfunction, or FSD.
Yeah, we're moving way beyond that simplistic, 20th century approach.
That failed search for a magic pill.
Yeah.
The whole pinking of Viagra idea, it just missed the entire landscape.
It missed everything. And if we distill all our sources down to one core finding, it's this. The whole conversation has definitively shifted to what's called the biopsychosocial model.
Okay, so break that down. Biopsychosocial.
It just means you can't separate sexual well-being from the whole person. You have to look equally at the body, that's the biology, the mind, so psychology and attention, and the environment, which is your relationship dynamics.
It's an intricate system.
It is. Disruption in one area instantly affects the others.
Okay, so let's unpack this system. I think we have to start with the biology, the medical foundation, since that's where the research, began. What are the common complaints? How does the medical world classify FSD?
Sure. For clinical evaluation and management, FSD is typically divided into 4 broad categories. These pretty much mirror the classifications clinicians use.
Right.
So first, you have disorders related to sexual pain, often called genitopelvic pain penetration disorder.
Yeah.
Then there's the pairing of low desire and low arousal. They're often combined into female sexual interest arousal disorder, and then finally female orgasmic disorder.
And when we look at the raw data, just in terms of prevalence, which of those is the one we see most often?
Oh, it's low desire, overwhelmingly, specifically something called hypoactive sexual desire disorder, or HSDD.
I've heard that term.
Yeah, the statistics are kind of staggering. Over 40% of U.S. women report experiencing some kind of sexual problem at some point. But here's the critical number. 11.5% of those women find it personally distressing.
So it's not just a problem, it's a problem that causes suffering.
Exactly. And HSDD affects a huge, highly distressed proportion of that group.
Okay, so we know it's prevalent. If we try to strip away the environment and all that mental noise for a second, what's actually happening under the hood? What does the neurobiology of desire even look like?
Well, a good way to think of it is like a car. The sexual response system needs to accelerate, but it also has a very, very sensitive set of brakes.
Gas and brakes.
Gas and brakes. The entire process is a delicate balance between these powerful excitatory pathways and strong inhibitory pathways.
So what's on the gas pedal? What pushes go out?
To increase desire, motivation, pleasure. That's your excitatory system. We're looking mainly at dopamine, which is all about the pleasure and reward pathways, and norepinephrine, which is essential for sexual motivation. Drive.
And hormones, I assume?
Of course. Hormones like testosterone and estradiol play huge roles, acting in the brain to promote desire and also peripherally to improve blood flow to the tissue.
Okay, and the brakes. The system that says, nope, not now.
That's activated by serotonin. Serotonin is the key inhibitory neurotransmitter here. It restricts those excitatory systems. So high serotonin activity is, often associated with sexual inhibition.
So when researchers talk about HSDD from a biological view, they're seeing an imbalance.
Exactly. Not enough gas, not enough dopamine and norepinephrine, and maybe too much brake, so too much serotonin restriction.
That model, too much brake, not enough gas, that really explains the pharmacological approach, right?
Mm-hmm.
So what are the actual evidence-based medical treatments that target this imbalance?
For HSDD, there are 2 main FDA-approved options in the U.S. The first is flavanserin, which you might know by the brand name Addy.
Right.
It's approved for, specifically, acquired generalized low desire in premenopausal women. And it works by decreasing serotonin and increasing dopamine and norepinephrine.
So it's trying to ease off the brake and push the accelerator at the same time.
That's the idea.
But Addy hasn't become this, widespread solution everyone hoped for.
Yeah.
Which suggests there are limitations.
Absolutely. While it's approved, the actual effect sizes in the trials were, modest. Plus, there's a big practical limitation. You can't take it with alcohol, and that's a huge factor for compliance.
That's a deal breaker for a lot of people's lifestyles.
It is. The second option is bremelanotide, which is delivered by injection. It's also for HSDD in premenopausal women, but it works differently, targeting what are called melanocortin receptors in the brain to boost those excitatory pathways.
What about for arousal or orgasm issues? Does something like sildenafil Viagra have a clear role for women?
It's mixed. For generalized low arousal, the evidence for drugs like sildenafil is, well, it's all over the place.
Why is that?
It seems women with arousal disorders are just a very heterogeneous group. But there was a randomized controlled trial that showed a very specific benefit. Sildenafil significantly improved orgasm and arousal better than placebo, but specifically in women whose dysfunction was caused by the side effects of SSRIs.
The common antidepressants.
The common antidepressants.
And that makes perfect sense because SSRIs work by increasing serotonin, which we just established is the neural brake system.
Exactly. And speaking of that, another medication, bupropion, which acts on dopamine and norepinephrine, has also been shown to be effective for that specific subset of FSD.
So it's clear the medical side has some tools, but our sources just keep stressing that focusing only on the biological side often fails.
It does.
This is the crucial pivot point. Why is the psychological layer so much more critical for female sexuality than it's often portrayed for men?
Well, researchers consistently point out that women's sexual response just relies far more heavily on psychological, cognitive, and attentional factors. And the major mechanism that can derail arousal is something they call the discordance problem.
The disconnect between mind and body.
Precisely. Women experience a significantly higher level of discordance between their physiological arousal, so what their body is objectively doing, like increased blood flow,
Right.
and their subjective experience of arousal, what they actually feel. The body might be ready, but the mind isn't registering the signal.
And this disconnect is even worse in women who are diagnosed with arousal disorders.
Much more pronounced, yes.
So the body is producing the physical response, but the brain is somehow filtering it out or ignoring it, and that prevents the feeling of arousal. How does that mental filter work?
It really comes down to something called interoceptive awareness.
Okay.
This is your ability to consciously register and interpret your internal bodily sensations, to know what your body is telling you. If your cognitive bandwidth is just full of noise, that awareness gets blocked.
And the physiological arousal stays disconnected from the subjective feeling. The problem isn't a lack of a physical response, it's the mind interrupting the reception.
That's it.
So what are the big psychological barriers the research points to that cause this interruption?
The researchers tend to categorize them into three groups. First is attention, just being unable to sustain focus or to notice and differentiate the subtle physical sensations of early arousal.
Right, you're just distracted.
Distracted. Second, and this is a powerful one, is self-judgment. So negative self-evaluation, feelings of guilt, inadequacy, anxiety about performance or your appearance.
All that internal chatter.
All of it. And third, clinical symptoms.
Yeah.
So coexisting anxiety and depression, which basically monopolize your cognitive resources and then fuel the other two barriers.
You know, this idea of self-judgment interrupting awareness, it sounds so much like the work of Masters and Johnson from decades ago, the whole concept of spectatoring.
It does, and the new research validates that observation completely. Spectatoring is essentially focusing on and evaluating yourself from this third-person external perspective.
Thinking about what you look like or if you're performing correctly?
Exactly. It's like public self-awareness, and it just breeds distraction and performance anxiety. The goal, of course, is what they called sensate focus.
The inward focus.
The inward focus on the immediate, non-judgmental sensory aspects of the experience.
And our sources cite this absolutely fascinating, if a little cruel, experimental proof of how damaging spectatoring is.
Yes, it was a great design. They induced this self-focused attention in sexually functional women by putting a reflective glass in front of them while they watched erotic films.
So they're forced to see a reflection of their own face while they're supposed to be engaged in the stimulus.
That's right.
I have to say, forcing people to stare at their own reflection while watching an erotic film sounds genuinely uncomfortable, but I guess scientifically effective. What happened?
The reflective glass significantly crashed their physiological arousal. It just plummeted. And this arousal was measured objectively using vaginal pulse amplitude, or VPA.
And VPA, just so everyone's on the same page, is the precise, objective measurement of blood flow to the vaginal tissue. It's the physical, undeniable sign of arousal.
Correct. So when these functional women were exposed to this self-focused condition, Their VPA responses dropped instantly. I mean, down to levels you'd see in sexually dysfunctional women.
Wow, so the mere presence of a cognitive distraction can instantly induce physical dysfunction in a healthy person.
Instantly, that is a critical insight. It proves that cognitive filtering and distraction aren't just secondary issues, they're primary roadblocks.
They are the problem.
They are, and they back this up with personality measures. They found that private self-consciousness, so the tendency to be introspective and aware of your internal state, was positively related to desire, orgasm, and satisfaction.
Yeah.
But public self-consciousness, worrying how others see you, was strongly associated with sexual pain.
The mind's focus is everything.
Immensely important.
So if the core problem is a cognitive one in attention and self-judgment, then the most powerful fix shouldn't be a pill. It should be a behavioral intervention aimed at dismantling those barriers.
And this is where mindfulness comes in.
Right.
Absolutely. Mindfulness meditation training, which is rooted in these centuries-old Buddhist practices, is designed to do precisely that. It cultivates non-judgmental, moment-to-moment awareness. It's a direct counter-intervention.
Did the research actually show that mindfulness training could specifically improve that poor interoceptive awareness you mentioned?
They did in a really powerful 12-week study on college women. At the beginning, the women took significantly longer than the men to accurately register and rate their bodily response to sexual stimuli.
So they were slower to tune in.
Much slower. And that delay was correlated with high anxiety and self-judgment.
Okay, so what was the result of the training?
The women who did the formal mindfulness training became significantly faster, 730 milliseconds faster, on average, at registering and accurately responding to their physiological arousal compared to the control group.
730 milliseconds. That's nearly 3/4 of a second of cognitive chatter and self-judgment just being stripped away. That is a massive, measurable improvement.
It is. It really speaks to the power of non-judgmental attention. And the mechanism was clear. The training led to improvements across all psychological barriers. They had increased attention, decreased self-judgment, and measurable drops in anxiety and depression.
And the faster reaction time was directly correlated with that.
Directly. The simple act of removing the judgment allows quicker, more direct access to the feeling of arousal.
That closes the loop on the individual beautifully. You have the biology and the psychology. But the model is biopsychosocial, so we have to shift to that third, equally powerful element, the relational context.
Right. Because the reality is that desire is rarely this spontaneous, purely biological urge, especially in long-term relationships. Context dictates everything.
So if the traditional model spontaneous desire leads to arousal, which leads to sex, if that often fails to describe the female experience, what's the alternative?
The research strongly champions the responsive desire model. This model suggests that the primary driver isn't a biological spark, but it's the pursuit of intimacy, emotional closeness, or other relational motives.
And those motives then trigger desire and arousal.
Exactly. The desire is the response, not the initial prompt.
And this framework was tested with those daily diary studies. What did the day-to-day data actually show about gender differences?
The results really underscore how context-dependent female sexuality is. For women, their sexual desire and the likelihood of sexual activity were significantly predicted by the previous day's relationship quality.
So the feeling of connection wasn't a result of sex. It was a prerequisite for even wanting to have sex.
That's it. Their satisfaction, closeness, and commitment on Monday predicted their desire and activity on Tuesday. And here's the punchline for the responsive model. The direct path from a spontaneous sexual desire to actual sexual activity was statistically insignificant for women.
Wow.
The relationship quality drives the motivation, not the spontaneous urge.
And for men?
For men, it was the opposite. The study found their sexual desire was not dependent on daily relationship quality. It was less context-dependent, aligning more with that traditional linear model.
That makes a relationship context itself a massive moderator. How did things like the length of the relationship or having kids change this dynamic?
These factors added fascinating nuances. In longer relationships, high daily relationship quality strongly encouraged sexual activity the next day. And then that sexual activity increased the woman's relationship satisfaction the day after.
So over time, sex serves this crucial regulatory function. It maintains the bond.
It maintains and promotes the qualitative aspects of the relationship, yes.
And what about the huge stressor of having children?
Well, the presence of children, unsurprisingly, negatively affected women's daily relationship quality appraisals overall. I mean, time constraints, fatigue.
Of course.
But paradoxically, having children increased the positive effect of that daily relationship quality on sexual activity.
Wait, so when they did feel satisfied, the motivation for sex was even higher because they had kids?
Yes. It suggests that in the complex, often chaotic environment of family life, when women feel connected, there's a greater motivation to use sexuality to deepen that emotional bond and cement their commitment.
And finally, what was that finding about sex as a restorative tool if the relationship was struggling?
That was maybe the most hopeful finding. If both women and men were generally less satisfied with their relationship overall, sex had a stronger positive effect on their daily relationship quality the next day.
So when the baseline is low, sex can act as a powerful intervention to boost closeness.
It serves a restorative or regulatory function.
Okay, so if we synthesize this whole journey for everyone listening, FSD is incredibly common. It's rooted in biological factors like neurotransmitters.
But those biological urges are almost always stalled by powerful psychological barriers, spectatoring, self-judgment, anxiety, that block our interoceptive awareness.
And the most effective counters are behavioral, like mindfulness, which helps dismantle those roadblocks so the body's signal can actually be received.
And most fundamentally, we've learned that for many women, desire is responsive, not spontaneous. It's driven by the relational context, closeness, commitment, satisfaction. This integrative approach is just crucial.
Addressing only the biology is likely to fail if you ignore the mental noise or the relationship dynamic.
Exactly.
Which brings us to this final, and I think slightly provocative, thought from the source material. It's about power and negotiation within a couple. The research noted that the sexual function level of the partner, male or female, strongly influenced whether desire actually progressed to sex.
That's right. When you look at the data from the couple, the partner with the better, or let's say, easier sexual response often dictates whether sex happens.
And that dynamic raises a really crucial, challenging question for couples.
It does. If the frequency of sex is largely determined by the partner whose sexual response is easier to access, how does the partner who's struggling with responsive desire make sure that their vital, non-sexual needs for intimacy and connection are still being met?
Without feeling pressured to engage in sex, just to stabilize or, keep the relationship going.
Right. That negotiation separating sex from intimacy, that is the real deep dive that this research demands we all undertake next.